good evening, everyone, and welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LIUNA, the Laborers International Union of North America. My name is Leslie Rattan, and I'm really pleased to be moderating our series, which runs every other week on Tuesday evenings from 6 to 7. And the sessions, just so you know, are recorded and are all available on the website. So should you miss a session or you want to go back and watch another session over again, you can find those all on the website. Before proceeding any further, we'd just like to acknowledge the Indigenous peoples of all the lands that we are on today. Even as we meet virtually, it's important to recognize the lands we each call home and reaffirm our commitment to improving relationships and understanding with local Indigenous peoples. From coast to coast, we honor the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. So just back to our webinar series, if you haven't been with us before, each session focuses on a different aspect of concussion, and we typically have an expert speaker who presents for about the first half of the session, and then the second half of the session is an opportunity for you to get any questions that you have answered. What I would ask that you do, there's a Q&A icon. If you just scroll to the bottom of the screen, you'll see that. Just enter any questions you have there. If you are having any technical difficulties, please enter those into the chat. And we have Brian tonight, who is kindly filling in for Christian, so he can answer any difficulties that you might have there. You'll also see that he has posted up a very quick poll. We always just like to get a sense of who's in the audience. So if you can just click on whichever one that matches you, that would be great. And there we go. So I'm really happy to welcome back Dr. Abe Snaiderman, who was with us last time. And Dr. Snaiderman's going to be continuing on speaking about mental health. The topic of tonight's talk is drugs for neuropsychiatric symptoms after concussion. And Dr. Snaiderman is an assistant professor in both the Department of Psychiatry and the Department of Medicine at the University of Toronto. He's the founding director of the Neuropsychiatry Clinic at the University Health Network, Toronto Rehabilitation Institute, Brain and Spinal Cord Program, where he has worked for the past 25 years. He's been involved in the field of physical and neurologic trauma for many years. As a clinician teacher, he has been involved in training medical students, residents, fellows, and ancillary health professionals, as well as the general public, also for over 25 years. He's a member of the exam board and an examiner in psychiatry for the Royal College of Physicians and Surgeons of Canada, and the winner of the Ivan Silver Award for Excellence in Mental Health, Education, given by the University of Toronto. He's a member of the Board of Directory and the advisory board of several acquired brain injury organizations, initiatives, and programs. So with that, I'm going to turn it over to Dr. Snaiderman.
Thank you, Leslie, for your kind introduction, and Brian for the technical help. I'm going to share my screen, and there you go. Okay, can everybody see well? If not, Brian or Leslie, give me a shout.
Yeah, looks good.
Perfect, thank you. For those of you who joined us 2 weeks ago and are ready for more punishment, here we go. So we're going to be talking about medications for neuropsychiatric, basically mental health issues, as symptoms of concussion. As always, given that I am affiliated with the University of Toronto, I have to make a disclosure, and I see no conflict of interest for this presentation, no affiliation with any pharmaceutical industry, especially since I'm going to be talking about medications. I will try to use generic names. Some of the slides have also the commercial names. I have no affiliation with any of them. I am a clinician teacher, as I said last time, and also, as I said last time, hence no research was harmed in the making of this presentation. I also have 30 minutes like last time, and that means Let's get going. So what are the main problems after mild traumatic brain injury? And I will be using interchangeably mild traumatic brain injury and concussion. So basically depression, anxiety, sleep disruption, memory issues, energy issues, substance use, and many, many others. For the sake of time constraints, we're going to be talking about the treatment with medications for these three conditions: depression and anxiety, and sleep disruption. Furthermore, when it comes to depression and anxiety, there's a symptom continuum. Can you see, Leslie, my cursor?
Yeah, just move it once again.
It's right at the top.
Uh, Sorry, go again.
Where it says symptom continuum.
Yeah, I'm not seeing it.
Okay,
Sorry.
no worry. No worry at all. So you're going to be seeing this. So you see symptom continuum.
Apologies, I do see it now.
Fantastic. Um, okay, so when it comes to symptoms, on one side you have worry, anxiety, muscle tensions, palpitations, sweating, dry mouth, nausea when you feel very anxious. On the other side, when you feel depressed, well, depressed mood, anhedonia means lack of pleasure seeking or not able to get any pleasure. Appetite disturbances, feelings of worthlessness, and in worst case scenario, suicidal ideation. But in between these two conditions in these Venn diagrams share sleep disturbances, psychomotor agitation, which means either you're agitated or really slow, difficulty concentrating, irritability, and fatigue. So when we talk about, on one side, generalized anxiety disorder, on the other side, major depressive disorder, what more commonly happens is that we have comorbid depression and anxiety. So we're going to be talking about medications that, not surprisingly, treat both conditions. Both disorders can be treated with so-called antidepressant, which is the most common term, but in reality, both are anxiolytics, means anxiety, lytics destroying off, so treatment of anxiety. Okay, so let's start with a very short video to explain how our brain works very quickly. Can you hear it?
Yeah.
A child's experiences during the earliest years of life have a lasting impact on the architecture of the developing brain. Genes provide the basic blueprint, but experiences shape the process that determines whether a child's brain will provide a strong or weak foundation for all future learning, behavior, and health. During this important period of brain development, billions of brain cells called neurons send electrical signals to communicate with each other. These connections form circuits that become the basic foundation of brain architecture. Circuits and connections proliferate at a rapid pace and are reinforced through repeated use. Our experiences and environment dictate which circuits and connections get more use. Connections that are used more grow stronger and more permanent. Meanwhile, connections that are used less fade away through a normal process called pruning. Well-used circuits create lightning-fast pathways for neural signals to travel across regions of the brain. Simple circuits form first, providing a foundation for more complex circuits to build on later. Through this process, neurons form strong circuits and connections for emotions, motor skills, behavioral control, logic, language, and memory during the early critical period of development. With repeated use, these circuits become more efficient and connect to other areas of the brain more rapidly. While they originate in specific areas of the brain, the circuits are interconnected. You can't have one type of skill without the others to support it. Like building a house, everything is connected, and what comes first forms a foundation for all that comes later.
All right, so you just saw an illustration in video of neurons, but how do neurons actually look? Let me get my pointer. There you go. So these are two neurons in a plate, so to speak, in what's called scanning microscopic, ultramicroscopic electron photography. So basically, you have two neurons with their bodies, their axons, and you see the dendrites here, the connectivity here. So you see in this illustration to the top right, what we'd call a synapse in red. That's the connection between one neuron, one of these long stems, to another long stem of a neuron. In real life, this is what synapses look like. We call those connections synapse or synapses in plural. And basically, they function really easily. It's a key in a lock type of connectivity. What do I mean by that? So this is one synapse, one cell connecting to the other cell, and the black space in between is called the intersynaptic cleft. So these triangular star-like figures are basically neurotransmitters. This, for example, is a neurotransmitter called opiate. Could be morphine, could be codeine. Now, each of these substances has a specific receptor, like a key that enters a lock. And this lock only fires when the specific substance or neurotransmitter lands in it. Once that particular neurotransmitter, say this is dopamine, lands on the right key, which is called a receptor, and this is the membrane of the next cell, of the synapse of the next cell, it signals this receptor to release more substances that then go to the next connection and produces neurotransmitter with specific orders depending on which neurotransmitter and which receptor. So this particular neurotransmitter will try to get in this one, but it's not the right key and lock and doesn't work. So what happens with antidepressants? How do they work? Let's say this is the membrane, the surface of one neuron in the synaptic cleft, and this is the next neuron. So this neuron produces from the center of the neuron a bubble full of neurotransmitters that travels all the way to the surface, fuses with the membrane, releases, in this case, dopamine, and dopamine floats in the space literally and ends up landing on a dopamine receptor, which produces an electric stimulation, which produces more substances. Now, what happens with this molecule after this lock spits it out? Well, there are other receptors that we call reuptake receptors, presynaptic. This is postsynaptic, post after the synapses, pre before the synapses, that literally recycle, scoops it up, recycles dopamine and brings it in. It gets destroyed or it gets recycled. The issue is that it limits the amount of neurotransmitter available in synaptic, in the space between the two neurons, to a certain amount. So again, it's very easy, very simple, lock and key. Or sounds that way. Now, what happens if we basically block this particular reuptake device, this reuptake receptor? What happens then is that there will be more molecules of dopamine or serotonin, as we will see, in the cleft between the two cells, consequently enhancing the activity of dopamine. Now, we don't get more dopamine or serotonin or norepinephrine. It's just that there's more dopamine available for continuing stimulation between cells. And that's how antidepressants work, for the most part. Now, neurotransmitters are very diverse in their type, their size, and their function. We're not going to go through this. So just as an example of some substances you have heard, perhaps, dopamine, like in Parkinson's, norepinephrine, epinephrine, serotonin, melatonin to help you sleep, many, many other substances, oxytocin that helps the uterus contract during childbirth, but also fosters bonding in new parents. Nitric oxide, when you go to the dentist and want anesthesia, that's also a neurotransmitter. If you were here 2 weeks ago, you would remember this slide with shows the monoaminergic nuclei. What does that mean? Big words. So these are neurotransmitters, and these are clusters of cells where the neurotransmitters are manufactured in the center of the brain. So your nose would be here, your eyes would be here, your ear will be there. So all of these nuclei, clusters of cells, all of these neighborhoods of cells produce specific substances. So these ones produce serotonin, noradrenaline, dopamine, etc. Now, after they are manufacturing these cells, they are transmitted to the rest of the brain through very, very long nerves called pontine basal cortical relays. So as you might have seen last couple of weeks, last session, is that whenever there's a damage in this area or in the long relays, the transmission of these neurotransmitters slows down, becomes inefficient, and many problems when it comes to cognitive thinking, feelings, and mood anxiety issues erupt. So what are antidepressants? Well, antidepressants are a group of medications or interventions, it's not just medications, associated with a decrease in symptoms and signs of depression. For example, non-medication intervention include exercise, psychotherapy, talk therapy of various types, meditation, contact socially, in some cases electroconvulsive therapy or transcranial magnetic stimulation, light therapy in the winter, especially now that it gets so dark. And medications are also antidepressants. Now, medications that help with depression have been around for a long time. The old ones from the 1950s and 60s started life as anesthetics and later on became more marketed as antidepressants, and they were kind of clumsy, clunky medications. Then the new-ish, starting in the late 70s, early 80s, and also are classified as the type of antidepressants, particularly which neurotransmitters are targeted. So the next slide's a bit busy, but bear with me. We'll go fast through it. As we said, in the 1950s, the main antidepressants were monoamine oxidase inhibitors. I just want you to pay attention, forget about the names, about the formula, the cycle. This represents one aspect. This is actually a graphic model of the molecule. So one aspect of the molecule is a circle, it's a hexagon, and then a tail. Those are the oldest antidepressants. And then came the newer ones, the tricyclics. Now, many of you are going to hear about tricyclic antidepressants, very old. And why are they called tricyclics? Because they have 3 cycles, 3 cyclic rings, all of them. And the more common one is imipramine. This is the oldest known antidepressant that is actually still around. Later on, tetracyclics. Why tetracyclics? Because they have 4 cycles. And then serotonin antagonists, which maybe some of you will be familiar with trazodone, which is used for sleep. And we come finally in the late 80s, early 90s to the SSRIs. Many of you would know of fluoxetine, Prozac, or Zoloft, sertraline, which were the first 2. This one became the most common ones because they're quite benign in their side effects and very safe to use, while the initial ones, monoamine oxidase inhibitors, were quite dangerous to use. There were quite a lot of dietary restrictions and they were dangerous agents. And later on, more antidepressants came about in the 1990s, like Effexor or desvenlafaxine or venlafaxine. But since then, there have been variations on the topics, but not new antidepressants have been developed. So going back to the types and names, tricyclics are the oldest ones, along with monoamine MAOIs, monoamine oxidase inhibitors. Now, these are the names of the most common ones you're going to hear out in the market and through your doctors. Citalopram, paroxetine, fluoxetine, sertraline, duloxetine, venlafaxine, desvenlafaxine, mirtazapine, and bupropion. So the question, we back the question, so which one is best? And rather than make it a boring slide or a boring graph, I thought, why don't we do an Oscar type of presentation? So let's say, and the Oscar for the best antidepressants go to, imagine there's loud music and there's a presenter that's fumbling, very well dressed and fumbling with the envelope, tries to unveil the envelope, the envelope is open, and The best antidepressant is, the Oscar goes to imipramine. But wait a second, I just told you that imipramine is the oldest one. As it happens, it is the oldest one, but it remains the gold standard. It's the best antidepressant. So we're going to give the Oscar, but unfortunately, imipramine could not be here to receive the award due to rather difficult to tolerate side effect profile. But in imipramine's absence, her daughters, the cipramine, clomipramine, and amitriptyline, oh wait, same side effect profiles. That's the problem with imipramine and all the other ones. They were very difficult to tolerate. People were constipated and sleepy all the time. They had problems with memory, very sluggish. They could affect vision. They could affect heart. And if the person wasn't careful, they were easy to overdose. We had to do blood work all the time to ascertain the level and electrocardiograms to see cardiac toxicity. Hence, they fell out of favor. Now, that said, the best results achieved in the treatment of depressive disorder after a brain injury, whether it's a concussion or a severe brain injury, is through the combination of medication and talk therapy. That's been very well established. So it's not just meds. What about using antidepressants after brain injury? So first of all, I'm going to show you my flow chart. What do I do when I see a new patient? First of all, I need to know what is the diagnosis. Is it a person who had a concussion and the concussion is not getting better, has gone on to develop post-concussive syndrome, as we talked about 2 weeks ago? Is it actual depression that predates the head injury, an anxiety disorder? Is it delirium, somebody acutely confused, or somebody very old that sustained a head injury, but in reality, the problem is that they were developing dementia? Or are there any other medical conditions? Is it a thyroid problem, anemia, iron deficiency? Are there any other diagnoses? Is the patient having problems with sleep or pain or other medical issues? As I said, anemia, thyroid, autoimmune disorders, infections, all of which can mimic depression and anxiety. The important thing is to choose the right medication for the right diagnosis, at the right dose, in the right patient, at the right time, for the right duration. That's my job. Basically, I just gave out my secret. That is what I do when I do a 2-hour or 3-hour assessment for a new patient. Now, what are the issues? How do I choose an antidepressant? Number one, who is this person in front of me? That is a human, not a patient. Let's deal with the human. What is the age? What is their gender? Not just the sex, but how do they identify themselves? That is important. Level of education, social financial situation. Are they involved in litigation? Is it a past medical history or a history of mental illness that I need to be aware of? What are the patient's personal preferences? They might prefer, no, I don't want to talk therapy. I want to get as fast as possible better, or the opposite. I don't want medications. I want talk therapy, or I don't want any treatment. Past experience or exposure to antidepressants. Have they been exposed to a medication that might have worked or might not have worked? And what about the family history? We know that if a relative had responded to an antidepressant, chances are genetically their offsprings or related siblings might respond to the same medication. And ultimately, what is the cost? That is an important factor. The newer medications tend to be more expensive. In my practice, I always use generics. I don't even use commercial names. I use generics, and I don't go for a new antidepressant right away. I typically wait 2 years before I prescribe a new agent to see what we call post-marketing experience. What about antidepressants after brain injury? So which one do we use? In mild traumatic brain injury or concussion, unfortunately, the scientific literature is very limited. It's very, very hard to recruit patients for these type of studies. So the numbers are not great. Now, evidence favors the use of the SSRIs, as you saw, which are the newer ones. Why? Not because they're new, because they are easier to tolerate and are now cheaper. They came down dramatically in price and they're easier to tolerate. What are the general strategies I use? Use the least invasive option. What does invasive mean? The agent that's going to fit the patient the best with the least side effects, the best chance of compliance, so the patient's going to stay on it. I always start very low in the dose, ridiculously low in the dose at the pediatric dose, and very slow if the acuity of the anxiety or depression allows it. If the patient is severely depressed and severely anxious, I might not have the luxury of go low and slow. I might have to act very quickly. Now, in brain injury, side effects are more common and more troublesome than in the general population. We're not sure why, but we suspect that the disruption in the brain causes more amount of medication to get in quicker and produce side effects. Having said that, the majority of the side effects, and we'll talk about it in the upcoming slides, are temporary and mild. Now, this is something important. There is a lag time of 4 to 6 weeks before they start working. Wait, what? I'm starting a medication that gives me initial side effects. Okay, they're mild, but I'm not going to see a response for 4 to 6 weeks. It's the vein of my professional existence. I don't know how many times I have to tell people, yes, it takes a long time for the medication to start teaching the cells in your brain to produce the right amount of genes to go down the synapse to the receptors that do the reuptake, the scooping of the antidepressant, to not work. And that takes 4 to 6 weeks. There's work in trying to develop agents that work faster, but as you can imagine, it's very long research. So yes, 4 to 6 weeks. The problem is that if the patient has side effects and stops the medication after 3 weeks and then tells the doctor, well, it didn't work, unfortunately, we don't know because we never had the chance of seeing whether the darn thing is going to work or not. In brain injury, my first line of treatment would be with sertraline or citalopram, not because they are the best, but they are the two that have the most evidence. The most research has been on sertraline or citalopram. If for some reason they cannot tolerate or there are contraindications, situations in which I cannot prescribe either of them, the next option would be venlafaxine. Or if the patient is in a lot of pain, say headaches or muscle aches, then I use venlafaxine. The third line is what we call tricyclics, as you saw, nortriptyline, amitriptyline, or imipramine. My colleagues in physiatry, rehabilitation medicine, and neurology tend to use these two quite a lot because they work really well at low doses to prevent headaches. Stimulants are another option, although that is way, way down the line. Bupropion is a medication that does not have the same side effects. That's called Wellbutrin. It's also used for smoking cessation. But it has a bit of a risk of seizures, so it's not a first choice. And definitely we don't use the old ones. How do people respond? Not respond to these medications. Not every person will respond to the first antidepressant. If you have a urine tract infection, and many of the women in this audience after a certain age, I'm not touching the age, but after a certain age will have urinary tract infections. And sometimes the first antibiotic works, and sometimes the second is the one that works, and sometimes the third is the one that works. Same with blood pressure and diabetes and migraine. So it's the same with antidepressants. Not the first option might not be the best. A common issue is underdosing. So commonly, the patient starts with, say, 50 milligrams of sertraline, and after 3 or 4 weeks, they see no response and they drop out of the treatment, when in fact, they might be breaking down the medication much faster than another person. What do I mean by that? When we take any pill, any medication by mouth, anything by mouth actually, it goes from the mouth to the esophagus, to the stomach, the stomach to the small intestine, and then immediately there gets absorbed and is sent to the recycling plant called the liver, which is also the garbage recipient. So the liver checks the substances and says, destroy, 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 destroy. But I'm too tired to destroy everything in this particular substance, so the rest can pass. We call that saturation. So whatever the liver destroys, which is a large percentage of the dose of the antidepressant, goes either through urine or through the bowel, and a small percentage enters systemic circulation and goes to the brain. So when I give a patient 50 milligrams after first pass, what we call first pass in the liver, maybe they're going to get, I don't know, 1 milligram in the brain. So in some patients, the liver works really fast, really well. And so it destroys a large amount of medication, and we have to compensate by increasing the dose. Now, oftentimes my patients say, oh my God, you want to increase the medication to 150 milligrams? That sounds like a lot. Good rule of thumb. The higher the number of milligrams, the weaker the medication. A medication that needs 1 milligram is way more potent than a medication that needs 150 milligrams to do the same thing. So forget about the number of milligrams. Occasionally, in severe cases that are treatment resistant, more than one antidepressant is needed. We call that augmentation strategy, and tends to be successful. Now, the response of your best friend's forever second cousin's neighbor does not predict yours. Beware of Dr. Google. Dr. Google has been scaring patients since 1996. So not because somebody had a fantastic response to one medication, well, you will have the same response. And the opposite is true. Not because somebody had horrific side effects to one medication, regardless of the medication, means that you will have the same. As I said before, family history of response or personal history of response might predict yours. And a minority of patients will not respond to medications, which we call treatment-resistant depression, at which point we do other types of treatments which are beyond the scope of this presentation. Now, what are the side effects? I made this graph. The bigger the circle, the larger the frequency. Not necessarily the severity, but the frequency. So if you see here, the number one side effect of virtually all antidepressants is sexual problems. Yay, Dr. Snaiderman, you took away my depression and now I'm completely chased. It made me gain weight. It's giving me some headaches and I feel tired. Thank you, Dr. Snaiderman. Again, the bane of my professional existence. The issue is that the higher the dose, the more the likelihood of sexual problems. What are the sexual problems? Typically, low libido, low sex drive. Might or might not be an issue. Typically in males and in females, difficulty reaching an orgasm, in the males, ejaculation, in the females, orgasm, or delay ejaculation, delay orgasm, which might not be necessarily a bad thing if the person has premature ejaculation. However, it does affect, and it's something we need to talk about. There are ways to fight the side effect, but it is there. Headache, dizziness, fatigue, and gastrointestinal symptoms like nausea, diarrhea, constipation tend to be short-lived. What does that mean? A week or two, and then they go away. And they're easy to treat. Weight changes. This is another issue that needs to be talked about. It's not that the medication is going to put on weight because you're retaining liquids. It's just that it's going to give you potentially a craving for the good stuff. Cannoli and pasta and chocolates and sweets and Tim Hortons and all that stuff. So it makes you crave it. It is controllable, and with the right education and exercise, it's not so much of an issue. Without all of those careful measures, patients can put on weight. Again, I have patients on one medication at the same dose, not putting weight, and another person, female, same age, or male, same age, same issues. One puts weight, the other one does not. It's unpredictable. There is a very rare thing called serotonin syndrome, which is literally 1 in a million. In the 30 years I've been doing this, I've never seen one. It happens when somebody's taking an antidepressant, and then unbeknownst to them, they take an over-the-counter medication like something for cold and cough or sinuses remedies over the counter that has pseudoephedrine or has a decongestion. And those medications, those substances do not get along very well with the compounding antidepressants in general. So a rule of thumb, don't be afraid of antidepressants. If you are on antidepressant and you got a cold, talk to the pharmacist at the counter and ask for something safe. And if the pharmacist says, yeah, you can take it, say, no, Snaiderman told me in a presentation I can't. You can take regular Tylenol, you can take regular ibuprofen or Advil, anything without a decongestion or cough suppressant, then that's fine. We go back to the symptom continuum. We saw this slide. So in one of them, you see sleep disturbances. That is the next most common complaint why people want help in my practice. Now, sleep disruption in mild traumatic brain injury is very common and very complicated. It's multifactorial, means many causes for the sleep disorder. The most common one is insomnia, meaning difficulty initiating or maintaining sleep. But there's also hypersomnia, sleeping too much, parasomnias, for example, nightmare disorders or certain movements during sleep. There's also the issue of whether there were problems with sleep before the head injury, what we call pre-existing sleep problems. We know that anxiety, mood problems, respiratory problems like sleep apnea, pain problems, neurological problems, environmental issues all disrupt sleep. So I have to do a very careful analysis of what the sleeping circumstances are with the patient. Now, sleep medications in mild traumatic brain injury, I like to call sleep medications a complicated, careless bunch like this guy from The Simpsons. Why I say that? Very common for people to be prescribed benzodiazepines. Okay, Dr. Snaiderman, what are benzodiazepines? Anything that ends in PAM. Lorazepam, diazepam, clonazepam. So Ativan, Valium, and Clonopin. Why are they difficult? Well, they tend to have problems affecting the person in terms of alertness, attention, concentration, memory, and they tend to get the person potentially habituated and addicted to them. So that's a problem. Another problem are the Z medications, Zopiclone or Imovane, Zaleplon, and Zolpidem. I don't even remember the commercial name of these things. I try not to use them. So these medications also have issues with problems in terms of memory and habituation, maybe not as bad as the PAM medications, but patients can also get habituated. Tricyclics, as we mentioned before, are friends or foes. Tricyclics, amitriptyline, nortriptyline, doxepin, imipramine, are really good medications for sleep. The problem is, as we said before, have a ton of side effects that are difficult to tolerate. Some antidepressants like trazodone and mirtazapine, which I didn't discuss in the previous slides, are actually quite good medications for sleep. They're not habit forming, they're not addictive, and they don't have the type of side effects that the tricyclics have and the problems with memory, attention, concentration that these ones have. Other medications that we prescribe in case of very severe sleep disruption are antipsychotics, but very rarely do we go for those. And other medications, antihistamines, Sleep Easy, the ones you see advertised and over the counters, which tend to have the same problems as the PAMs. People get habituated to them. They have problems with attention and concentration. They have problems with the coordination. And at the end, they stop working. So we don't go for them. So lorazepam, diazepam, clonazepam, the Zs, no, in my book, Amitriptyline or triptyline, maybe, particularly if there's pain involved. Trazodone, mirtazapine are go-to medications, and the other ones, perhaps not so much. But again, let's go for the Oscar of the best sleep medication. So once again, a new presenter comes in, nervously, she opens the envelope and goes, and the Oscar for the best sleep medication is none. Why? Because that's not the way to treat sleep disorders. Sleep disruption in mild traumatic brain injury, we need to treat the underlying cause. Now, it's easier to just prescribe a medication for sleep and see you in a couple of weeks. Tempting, but it's not the best for the patient. So we need to find out why the person is not sleeping, what's going on. Example, the patient might be snoring like a locomotive, and the wife or the partner tells us, I can't sleep with this person. So that means that they might have sleep apnea, and a CPAP mask might be all they need. They might be having problems sleeping because they need a lot of pain, and an analgesic like ibuprofen might help. There is cognitive behavioral therapy for insomnia. Of all the treatments for sleep disruption, this is the one that has the most success, and not so much in how successful it is, but how lasting the changes is. You can find CBTI anywhere online. It's become very popular. Some sites, sometimes you get it for free. There's YouTube's channels on how to do it. Straightforward. Exercise, underprescribed, underused, fantastic sleep aid. Structure bedtimes and awake times. Go to bed at the same time, but wake up at the same time and don't nap. Avoid caffeine, alcohol, recreational drugs like cannabis, tobacco, and this is another bane in my practice, screens. How many of us go to bed with a phone or a laptop or watching TV? And all that blue light basically tells the brain it's daytime, wake up. So how are you going to fall asleep with that? So no screens 30 minutes before at least you go to bed. Exercise. Did I mention exercise? You're going to get my drift here. Limit liquids 3 hours before bed. If urinating in the middle of the night, what we call nocturia, is the problem why you're not sleeping. If you're a man of a certain age or a woman of a certain age, particularly if you have kids, you might need to talk to your family doctor about this and might need to go to see a urologist or a gynecologist to see why you're having so much trouble with nighttime urination. Exercise. Did I mention about exercise? So if we go through all of these things and the patient is still not sleeping, then I would go for trazodone as a first choice and mirtazapine, which are the least complex and the more benign medications. So just to finish, this shows how science is, I'm such a big fan of science. Every year, something comes up that makes our jaw drop. During the COVID pandemic, we found out that patients who were prescribed antidepressants of the SSRI died less than the ones that did not go on them. And we're scratching our heads, how does that happen? And we're starting to see how these type of medications not only help the brain reconfigure, also might help the brain regenerate in certain injured areas. The talk is, I don't have enough time to go through that, but it is fascinating. So trial and error approach when it comes to medications. I love this slide. Gary Larson's The Far Side. It says, God as a kid tries to make a chicken in his room. Boom. So the first experiment sometimes doesn't work. We need to continue trying. Depression and anxiety, sleep problems are treatable. Please seek help. Thank you for your attention, and I'm going to stop sharing.
Thank you so much, Dr. Snaiderman. That was excellent. So this is a time, if you have any questions for Dr. Snaiderman, please enter those into the Q&A. We do have a couple so far. Someone was asking about memory loss. So I guess if they've got memory issues, is that a consideration in terms of medication that they're taking?
Let me understand the question. How about increased memory loss in the context of brain injury, I imagine?
I'm assuming so.
Okay, so let me go really quickly through this. If you're depressed or anxious, you're not able to pay attention and concentrate. If you're not able to pay attention and concentrate, you cannot register the information. If you cannot register the information, you cannot file the information, what we call encoding of the information. If you don't encode the information, you cannot retrieve the information to then use it. So being depressed, anxious, and sleep deprived definitely affects memory. If on top of that, you add age or recreational drugs or medication that can affect memory or lack of exercise and stress, definitely we see that as a problem. And if you add a concussion with pain, definitely we see people with having attention concentration. Now, we can have a 16-year-old with a concussion having attention and concentration, and they don't have Alzheimer's disease, they don't have dementia. So what we need to rule out is this other stuff that might be interfering with how they're encoding information. And I see here that says memory loss from TBI. Yes, you can get memory loss from TBI, but this is unfortunately not the right presentation to talk about this. It'll take me another hour to talk about that.
Yeah. Okay, thank you. We have a thank you. You made a very difficult topic, very enjoyable to listen to.
Thank you.
And then we have a question. Has there been any scientific study about the effectiveness of alternative medicines, such as cannabis?
Yes. There's a large study for the past 5 years that we call naturalistic, which means it happens on its own, which is legalization of cannabis. So in the next 5 to 10 years, we're going to see the consequences of what legalization of cannabis has done. I'm not saying it's bad or good, but we do know certain things, and I'm going to sound like a prude, but bear with me. I don't care whether you smoke cannabis for fun or not, I don't care. But I do care about the biochemistry. And being based in science, I go by data. And we do know that cannabis has more than 130 compounds, out of which we know 2, THC and CBD. We don't know what the other ones do, assuming the cannabis plant has no pesticides or contaminants. So just that. Now, we do know that the brain has cannabis receptors, which is an incredible thing, but the brain has 2 types of receptors, CBD1, CBD2. Those receptors, remember the slides I showed you, the key and lock? When the cannabis molecule goes into the receptor, blocks it, several things happen in the brain. You get a relaxing effect, but at the same time, attention, concentration, initiative go down. Mood can go down, and anxiety after the effect of the cannabis wears off can spike up. So we're not sure what it does when it comes to memory, but if you're stoned and inattentive, I'm thinking Cheech and Chong, you're not going to be able to pay much attention and learn. So this is why it's so crucial that when you're using your brain in your youth to learn stuff in school, in high school, and afterwards, perhaps any other activity you're going to be doing, you need your brain fresh to learn the stuff that's going to save you the rest of your life. So if you're bringing in substances that dull your brain, whether it's cannabis or cocaine or alcohol, the #1 neurotoxin, nothing kills brain cells better than alcohol. Well, maybe mercury, but we're not eating mercury, I hope. But alcohol is a neurotoxin. If people are, it kills me. Sometimes I have patients that tell me, I'm not going to take your medication because it's a chemical. And I take their history and they're drinking 4 beers at night and two joints. I mean, that's chemicals.
It's chemicals, so choose your chemicals carefully. So I don't prescribe cannabis for anxiety or depression. I don't prescribe cannabis for anything, basically, especially for concussion. The only reason why I would say, go ahead, get yourself a doctor to prescribe cannabis is in somebody with intractable pain, in palliative care, or that has a degenerative illness for which we have no adequate treatment, and we're using it to basically improve quality of life by decreasing severe pains, severe spasticity, etc. But in somebody who is otherwise healthy, I'd rather not.
Okay, thank you. I was diagnosed with idiopathic hypersomnolence many years ago. Could this be linked to my current PCS, mostly experiencing headaches and some sleep disturbance?
So, okay, let me understand. So hypersomnolence, what was the second part? That would that be, is it PTSD?
Sounds like they were diagnosed with the idiopathic hypersomnolence many years ago.
Right.
And then I'm not sure, but it's sounding like the post-concussion symptoms. So it sounds like that's happened since that diagnosis. And they're wondering if there's some link, I guess, between the history of that diagnosis and their current symptoms. I think that.
Tough question. Thank you.
Yeah.
With me, when I know something, I will tell you that I know, and I tell you what I know. But when I don't know something, I'll tell you also I don't know. This is such a specific illness, hypersomnolence. I'm going to assume that it's not narcolepsy, that it's idiopathic hypersomnolence. You're fatigued all the time and you need to use a stimulant. And afterwards, you got a concussion. I'm going to assume that's the case. It complicates the picture because after a concussion, and assuming the concussion did not resolve in the first 3 to 6 months, which 90% of concussions do, and you're in the 10% that remain symptomatic, it'll be complicated to ascertain, to tease out what is the pre-existent hypersomnolence and what is new onset symptoms of concussion. So hard question. I think both will be very difficult to tease.
Yeah. Next question, is there delayed depression after a concussion, or does it come on immediately?
Great question. Depression after a concussion can happen at any time. More often than not, we'll see it weeks to months later when the patient remains symptomatic. If you were present in the talk I gave 2 weeks back, there's a vicious cycle of concussion, symptoms, non-resolution of symptoms, anxiety about why you're not getting better, anxiety increases, perception of the symptoms, which increase the symptoms themselves, which increase anxiety, which decreases mood. So typically we start seeing depression weeks if the person is already predisposed to depression. And if they never had depression, then months after. So yes, there can be a delay, and sometimes in untreated patients can happen even later. It's important to treat it because that's one of the easiest things to treat and improve quality of life.
Great, thank you. Ralph is asking, is there a connection between a memory loss or memory loss from a concussion to dementia?
Okay, Pity Carmela. Well, Pity Carmela Tartal is not here to give you a much better answer than I can, but I will tell you what we know. If you have 1 concussion, 2 concussions, the chances of you developing dementia later in life are very remote, very, very small. If you, on the other hand, are involved in an activity that gives you concussions all the time, like boxing, I don't know, I'm going to keep on saying until I die, why boxing and wrestling are still sports, and Olympic sports at that. Don't get it. The whole gist of boxing is give the other person a concussion, if not a severe brain injury, and knock them out. That's a concussion. But anyway, if you're not a hockey player or a football player or a boxer, or you're not exposed to jobs that
will give you dangerous exposure, like soldiers next to explosive devices or bombs and things like that. The chances of you developing long-term dementia are very, very small. If you want to minimize those risks, treat your brain right. Try to sleep as best as you can. Exercise. Have you heard that before? Exercise, exercise, exercise. The same thing that goes for your heart. If your heart vessels are open, if your coronaries are nicely and open, that means that chances are your vessels, your arteries up in your brain are going to be open, and they're going to bring all of the good stuff to the neurons and take away the bad stuff from the neurons. You're going to stay with a younger brain. So treat your brain right, and your chances of having problems in your dotage decrease. There's also genetics, there's also bad habits, there's also other factors, but 1 or 2 concussions, I wouldn't worry.
Great, thank you. Next question. I've been on tryptophan, 1,250 milligrams for 25 years. Helps with depression and sleep. Had 2 concussions 12 and 5 years ago, and they've left me struggling with daily headaches. Is it worth switching to another antidepressant?
Good question. Tryptophan is the precursor of serotonin. So tryptophan is just like you baking a cake, that's the flour and the eggs. That is a precursor. So out of tryptophan, through different changes in the body, tryptophan becomes serotonin. One of the problems with tryptophan is that it can be sedating, which is why people use it for sleep. The other problem is that a large percentage of it gets destroyed in the stomach and the liver. So we don't know how much of that tryptophan actually reaches the brain. If you are struggling with post-concussive symptoms, and you're finding it that you're not getting the same response for tryptophan, it would be worthwhile gradually discontinuing tryptophan and going on an antidepressant. Do not mix those two, because that can produce the above mentioned serotonin syndrome. So you have to taper one slowly and then start the new medication. Talk to your doctor about it.
Great, thank you. Rachel's asking, do you think it's a good idea to take a test that can tell the patient if their system can or cannot tolerate certain prescription drugs, so that there might be less of that trial and error?
That's called, thank you, Rachel, great question. Pharmacogenomics. Basically, there are, I think, some of the labs are selling, are advertising that you can buy genetic testing to see whether you are more likely to respond to X, Y, or Z antidepressant. The jury is still out. It's exciting field, but the articles that I read in the scientific literature keep going back and forth. I've had maybe 10 patients in the past 5 years or so that decided to go and pay $300 to do the test. And we found out that they were supposedly more responsive to X medication. Some responded well, others did not respond. We don't know how accurate these tests are. We don't know how, from generalization to individualization, can be. In other words, are they right for you? And are they accurate? If you want to spend the money and try that first, sure. I imagine that that's the future. I don't know if it's ready for prime time. I imagine that's the future. And before somebody asks me a question about ketamine or LSD or mushrooms, which inevitably they come out, they're not yet ready for prime time either. The people who are studying this here in Toronto, UHN, and Sunnybrook, etc., are having very good results, but they're still preliminary. We don't know long-term effects. We don't know how often these treatments need to happen. They're really expensive. One of my patients just went for a ketamine infusion, paid $8,000. So not yet ready for prime time. In the next 3-4 years, we should have more information.
Okay, that's great. Thank you. What could be the potential reasons why someone initially responds well to different types of antidepressants for a few weeks, but then their symptoms return to the original level of struggle despite continued use?
That's a good question. The answer is we're not sure and depends from person to person. The first thing is, and I'm not saying this is you, I have no idea, but the most common thing is the person taking the medication as prescribed. We all forget medication. The worst when it has to come with an antibiotic for whatever reason. So yes, is the person taking the medication? Is the person taking the medication with other medications that might be bringing the level of the antidepressant down? Is the person taking the medication at the right time and at the right dose? In some cases, we've seen that people kind of run out of steam of the antidepressant, and it might be that the liver got smart and started destroying even more of the medication in first pass. Or it might be that the brain kind of ran out of steam for this particular medication and it's not the right one. I have seen that. That's why we use augmentation strategies. So if one antidepressant is working and then it kind of stops working, but typically not just for a few weeks. When this happens, it happens after quite some time, months. If it's a few weeks,
Yeah.
I wonder whether there's something else happening and whether the diagnosis of depression is right.
Okay, thank you
Basically.
very much. Well, I see we're actually over time. There were a couple of questions that we didn't get to, but I will just remind everyone that there will be a very short survey coming your way, as there always is. So we really encourage you to fill that out, provide us with any feedback that you have. And if you do have a question that didn't get answered, you can include it in there. Just be sure to put your contact information because the surveys are anonymous. So sometimes people put questions in, but I have no idea where they're coming from. So just a reminder to do that. And thank you so much to Dr. Snaiderman for being with us for the last 2 sessions. It's been fantastic. Our next session is December 3rd, and we have Eden Dales, who's going to be talking when and why to consult a social worker. So thank you again to everyone that attended, and we'll see you in a couple of weeks.
Thank you, and please fill your evaluations, otherwise we don't know what we're doing well or not.
Exactly, yes. Thank you so much.
Thank you, Dr. Rutan, as always, a pleasure. Thank you, Brian.
Thanks, Brian.